Good evening, everyone, and welcome to the presentation for tonight. My name is Belinda, and I'll be hosting tonight for our presentation. Just give me a moment, and I will share our presentation with you. So tonight's presentation is the third session for a walk on the website. It's about communication challenges in palliative care and EOL discussions. Just bear with me, I'm having a few troubles trying to get this presentation working. I was working in practice before.
Linda?
Yes.
It's John here. Do you want me to try share screen?
Yeah, I think I might need you to. I can't get my share screen.
All right, just a tick.
Oh, no, actually, I've just found that this should work, and hopefully you're seeing the screen now.
Yeah.
So I'd just like to acknowledge and pay my respects to the traditional custodians of the land. I also pay my respects to their elders past, present and future. I would also like to extend my respect and acknowledge any Aboriginal and Torres Strait Islander people that may be present here tonight. As I mentioned, my name is Belinda. I'm the Regional Services Officer for Gippsland PHN out in Wellington, East Gippsland. So tonight there'll be CPD activity points will be allocated on completion of the event. In order to obtain those CPD points, you must submit the evaluation survey at the end of the event and include your RACGP or ACRM member details. The survey will be sent to you via a link in an email. Now for tonight's presentation, can I please ask that everyone has their microphone muted and your video off unless otherwise instructed. Any questions, I will request that they are put in the Q&A section of the presentation, which will be found down the bottom of your screen. In the middle, you'll see a little box saying Q&A. We will have time to answer questions at the end of the presentation. Any questions that you do see that are similar to yours, please just click to promote that, and we will try and get to them at the end of the presentation. The documents will be made available on request. I don't believe we are recording tonight's session. That won't be applicable. There will also be an evaluation survey emailed out post to the event, and a statement of attendances will be sent out once your surveys have been completed. Just in relation to tonight's event, Gippsland Health Pathways do have some localised palliative care pathways. You can see them on your screen at the moment. We will send out some information on that as well. The population health data deaths in Gippsland, we know that in 2016 there were a total of 2,556 deaths in Gippsland, the majority of those being in Latrobe, which encompassed 28% of those deaths. Hospital admissions for palliative care in 2016-17 were predominantly in the Latrobe region as well. We did find that East Gippsland and Wellington were very close behind, which is quite indicative of the older populations in those areas. Now, we do have two presenters for tonight. The first being John Reeves. John's a clinical psychologist in a private practice and has worked in Gippsland for over 30 years. His clinical practice is focused mostly on the treatment of adults and older adolescents who present with anxiety, depression, stress-related illnesses, and the effects of psychological trauma. He has facilitated for the GRPCC, the Cancer Council of Victoria, RACGP, and the GPO-GPA program since 2014. He is a conjoint senior lecturer for Deakin University Centre for Organisation Change in Person-Centred Healthcare. So we welcome John tonight. And our second presenter is Indra Jayasinghe. I hope I pronounced your name right. Indra is a dual specialist in palliative medicine and general medicine. He is currently working as a palliative specialist at Gippsland Regional Palliative Consultancy Services and at the Alfred Hospital. He also works as a general physician in community health for Peninsula Health and in the general medical unit at Cabrini Hospital. He has a graduate certificate in healthcare development and is also interested in developing palliative care services in regional areas. And we welcome you as well, Indra. So thank you, John and Indra, for making time available tonight to present to us, and thank you for all the attendees here. We will be keeping an eye on the Q&As and the chat functions as well, so please do pop your questions in there as we go along. And I'll hand it over to you, John, to start your presentation.
Thank you. Okay. So good evening, everybody. Thank you for coming along to this session on communication challenges in palliative care and end-of-life discussions. As Belinda said, I'm a clinical psychologist. I have occasional contact with patients at their end of their life, but my main interest in this area has been as a training facilitator for the last 10 or 15 years, working with clinicians from medical students across Gippsland all the way through to from Wonthaggi to Mallacoota. We've worked with students, allied health professionals, GPs, consultants and so on, and provided these training workshops in GP clinics, hospitals, health centres and a range of other settings. I just wanted to sort of set the scene to some extent for tonight. This is not a formal skills training workshop. If it was, we would be doing it with many fewer participants, and it would be a much more intense behaviourally orientated session. But we will be covering some of the issues in background, talking about some general skills and tips for engaging in difficult conversations. I'm going to show a short video, which is a demonstration video about an advanced care planning discussion. And then Indra and I will both make some comments about end-of-life care discussions in the context of telehealth, which we've all no doubt had plenty of in the last several months. So good on you for showing up for yet another Zoom dose this evening. We really appreciate it. Just one more comment. There is a considerable amount of information on the PowerPoint. We won't get to time to cover all of those. I will address a few salient points on the way through. And of course, there'll be opportunity for questions as we proceed. So we might just start getting into it. The task of clinical communication really fundamentally, from my perspective as a facilitator and a psychologist, has to do with two issues. One is trying to identify what's the matter with the patient. So that's the clinical presentation, the medical history, examination, diagnosis activities. And the other issue, particularly in the context of end-of-life and palliative care, is what matters to the patient. And even when we aim for trying to understand the complexity of the patient's experience, including their medical diagnosis and trajectory, there's more to the patient than just their diagnosis. And the issue that I guess we are mostly interested in addressing in these kinds of discussions is, how do we learn as much about the patient as possible so we can give them the best possible care? And really, Chochnov's question here lies at the heart of patient-centred healthcare and shared decision-making. We can only really engage in those activities competently if we know something about who the person is. So even when we aim for that lofty goal, there are a number of issues and challenges. And this is really the context for the training work that I've been involved with, as I said, across the region for a number of years. And there are some things which stick out in the literature reasonably consistently. One of the issues is the extent to which we have made clear what the purpose of a particular interaction is between a clinician and a patient, whose agenda is the focus of the consultation, the extent to which we have actively elicited and supported the patient in contributing their agenda and listening to their concerns. We also know that the issue of verbal and non-verbal cues in relation to what we know and what we can learn about the patient is also vital. Patients on average give 3 or 4, perhaps half a dozen verbal and non-verbal cues per consultation. And not in all cases by any means, but in many cases those cues aren't identified by the clinician, and nor are they then responded to in a way which adds to the clinical picture. Another issue is really the relevance of psychosocial factors, and some reports have indicated that in this particular domain of practice, in up to 80% of the cases, the psychosocial issues just don't get on the agenda at all because of other seemingly more pressing concerns. So these are the things that make the challenge of having difficult conversations more difficult than they otherwise might have been. And we know that some fundamental skills and awareness and attention to some of these issues can result in enhanced communication efficiency, which has been defined really as how do we optimise the quality and the accuracy of the information that's obtained in a particular consultation. It's our experience, and trainers in university medical schools have reinforced this, that if you're over about 40 or 45 years of age and a practitioner in Australia, it's fairly likely you've had very minimal formal clinical communication skills training, even though it's at the heart of absolutely everything we do. So many clinicians are just not aware of issues pertaining to agenda setting and rapport and cue responding. So we'll talk a little bit about that tonight as a bit of a taster for what you might consider down the track. I've included this slide as a bit of a provocation, but also because it is a truthful, if somewhat extreme, statement about patients and the vulnerabilities they present with. We know that patients with serious illnesses have elevated levels of anxiety, and their levels of anxiety make them exquisitely attuned to what's going on in the consultation. They are particularly attuned to the process of rapport building, and there's good evidence to suggest that a rapport is well on the way to being formed within the first minute, and perhaps even less than that. Some researchers indicated that the ratings that patients make of perceived rapport at 1 minute predicts their rating at 15 minutes. So first impressions count. The way we greet patients, the way we address them, whether we use names or titles, are crucial to that initial formation. Patients are also highly sensitised to potential inconsistencies between what we say and what we do. And perhaps a somewhat oversimplified example might be the clinician who says, thank you for coming in today, we've got plenty of time, there's no limit on what we can cover today. And then 3 minutes later is noticed looking at their watch. Patients pick these things up. They're reluctant to present them in many cases as issues because of their underlying anxiety and their fears about the relationship being compromised if they event some of these concerns. Patients are also very attuned to the tendency we have on occasions when having difficult conversations to avoid or evade or fudge or present information in such a way which is inconclusive. And I guess this reveals one of my primary interests in doing this work, that because this is anxiety provoking for clinicians, we know that the hallmark behavioural indicator of anxiety is avoidance. And there's no question some of these challenges in dealing with very sick patients promote our own anxieties, and therefore we might be less inclined to tackle what issues that might be actually quite fundamentally important for the patient themselves. The other meaning of X-ray vision is that patients know what they want, and they don't want to end up here, mostly. Some surveys have indicated that 70% plus of Australians would rather die at home, and yet sadly that is not the outcome for many people, despite that preference. The other aspect of understanding patients really surrounds when do we think about having some of these discussions with patients who might present with serious illness and for whom we have grave concerns about survival. And the GRPCC has developed a lot of resources which are available from the website, and you may have seen some of them in the previous seminars that Melanie has conducted. And one of the trigger questions that is relevant to timing is, would I be surprised as a clinician if this person was to die in the next 6 to 12 months? The relevance of that question is that if the answer is no, I wouldn't be surprised. It provides us with an opportunity to start having a conversation with the patient and their family about potentially what lies ahead. Given that we know that patients who have earlier referrals to palliative care certainly have better quality of life, and in some cases have modest increases in longevity. Seems a good reason, or a good couple of reasons for thinking about asking the question. The other aspect of patients having a vision, being able to see things and understand things, is that they know what they want. Clearly, some people will hang on for everything they can get in terms of medical treatment, but the vast majority of patients seem to have preferences which are in other directions, maintaining their dignity, minimisation of distress, and being able to optimise their independence. And all of these issues really can only be addressed if we have a mechanism for discovering from the patient what it is that's important to them, what matters to them. And the ways in which we go about that, our own level of competence and certainly confidence in addressing some of these issues is really fundamental to the communication challenge surrounding these presentations. Unfortunately, these discussions don't necessarily happen in a timely manner. And as this research suggests, prior to admission, only 3% of the patients in this study had a goals of care discussion, despite the fact that we know it's helpful for health system management and also helpful for patients. The other thing that I think is really noteworthy about this particular paper is that, contrary, I think, to the expectations we often have, the overwhelming majority of patients and their carers did not find and do not find these discussions unreasonably stressful. In fact, my own impression is that provision of information skillfully provided gives patients the opportunity to take some control. And control is something, perceived control has been demonstrated time and time again as an extremely helpful variable in reducing the impact of anxiety and therefore other aspects of psychosocial difficulty and suffering. And this kind of framework or awareness, I think, extends to another issue that's certainly been in the literature for many years, about the choice, the apparent choice, and maybe even tension between honesty and hope. The idea, and we've had these discussions with learners across a range of settings, both established clinicians and junior trainees, that they feel very reluctant about being honest because the fear is the patient will be overwhelmed, they'll drop their bundle, they'll decompensate, we'll have a Pandora's box of psychological challenges and deficiencies in coping, which will just add to the entire burden of managing the patient. But the research doesn't really support that contention, and it seems that as the title says here, honest disclosure done skillfully and empathically does not destroy hope, and may in fact do the opposite. It's obviously a matter of how we do this. How do we convey honest information about prognosis? But it doesn't seem that the fear clinicians often have is really validated by the evidence. Another issue, and you'll notice in these next couple of slides there are some purple bubbles. The bubbles really signify some of the communication strategies and skills that are relevant to these communication challenges. And I was drawn to this paper, I guess, and the ones that follow, because of the discrepancy between what we might hope is the case and what the research tells us may actually be the case. We have to somehow deal with and find a way to confront why it is that only 53% of patients who wanted a prognostic discussion actually got one. It's a rather confronting bit of data, really, and of course it's sort of amplified by the fact that in this paper, at least, only 31% of patients got an end-of-life care discussion. Only 25% got a palliative care discussion. So these are significant challenges, and we're entitled, I think, to ask ourselves, A, how does this happen? But B, how do we do this better? Similarly, in the issue of concordance, it's quite startling to read that 96% of the patients in this study had a more optimistic estimation of their prognosis than the oncologist did. So it suggests that patients are forming ideas based on their experience that are not necessarily the focus of interactions between clinicians and patients that might correct some of those discordant perceptions. And I guess the backstory, the elephant in the room here, is when it becomes obvious that the patient's prognosis is vastly different from what they were expecting, then we potentially do have a serious crisis on our hands in terms of how the person is able to cope with that, particularly if their disease is at an advanced level. And finally, on these purple and green slides, another quite startling bit of data that 55% of the patients in this study, and they were advanced cancer patients, inaccurately believed that a cure was on offer. Once again, we're entitled to ask ourselves, how does that formation, how does that view get formed, and what do we do about it? What are the skills and what are the strategies that might actually assist us provide patients with information that enables them to plan and take some control over the time that they have while they are well enough to attend to those priorities they might otherwise want to see out and address in some way. So we've got quite a lot of evidence that the information, the coherence of information and the extent to which patients and clinicians have shared perspectives is a major issue in this area of healthcare. Okay, what I'd like to do now is show you a brief consultation that my colleagues and I have put together. It runs for about 5 minutes. We'll be interested in your feedback at the end if you're in a position to provide that. It's a demonstration of an advanced care planning consultation with a new patient. So here we go.
Hi, Joan. My name is John. I know you've been a patient for some time. That's the first time that you met.
That's right.
So what's brought you here?
Oh, John, I've just come back from Melbourne and they said I have to go and talk to my GP about palliative care referral.
Okay. And was any information given to you about what that means?
Not really, no.
So, originally, what did you know about palliative care?
Well, I guess it's where you go to die.
Okay. Well, palliative care is certainly something we consider when people approach life. It's not actually just about that. It's also about care and care in the form of pain and support. It's a team approach. So we might come back to that, and I'll make sure we cover that before we finish today. Can you tell me a little bit about what happened in Melbourne? Just the recent summary about what happened when you were there.
Yes. I went there to get the scan results and for my cancer, and I didn't think it was going to be great news, and I was right. My husband thought that it would be a better result than it actually is. But yes, they basically told me that my cancer has spread, and that I've probably only got about another 6 months, if that, to be here. Yeah.
Was that news you were expecting yourself?
There was a large part of that I was expecting. Yes.
And Darby?
No, he was very much about, come on, Joey, we've got to keep fighting. Come on, Joey, let's see if there's some more treatments for you. And it comes as a real shock to him.
Okay. So is he sort of, if I can put it this way, you feel depression?
A little bit, I do, yes.
Okay. What do you actually want?
I just want peace and quiet. I'm sick of the circus.
Okay.
Yes.
Okay. So what would peace and quiet look like for you?
Yes, just to go back to the farm and just be there and have a nice, peaceful exit. Yeah.
Look, one of the things I wonder if we could talk about briefly today is, because it is relevant for the next 6 months, has anybody talked to you about an advanced gender?
No.
Okay. Would it be okay if I just gave you a very brief overview of what that is, because I think it might actually be relevant.
That is fine, yes.
So look, in very simple terms, an advanced care plan is a way of documenting in advance what you want in terms of treatment, support, and interventions, and what you don't want between now and the end of your life.
Okay.
It involves a discussion with you, probably over a couple of consultations.
Right.
2 or 3.
Yeah.
And we can also involve family members if that's relevant. Okay. But it gives us a bit of a roadmap.
Yes.
Okay. And it gives you, we often know that when people have a plan, they have a sense of being in control, often it's worried because they actually know things have been put in place.
Oh, yes. That does sound like it makes good sense, yes.
So we won't be doing it today because I will give you some information to take home.
Sure, good.
If possible, I'd like you to think about an appointment in the next week or so and maybe bring David in.
Yes.
Because I think there's probably some interest to sort of.
Yes.
But for today, what I'll do is follow up with the referral that we've received from the hospital, and I need to create some paperwork essentially to create a community care referral so that we can get some of those aspects organised as soon as possible.
Yes, they will keep on top of my pain, they said down there in Melbourne. Yes, yes.
Okay, so look, thanks for coming in. I'll look at that paperwork. We'll put an appointment schedule for you before and I'll see you.
Yes, okay. Thank you. Yes,
Also.
Okay, so that's a brief video, about 5 minutes. We learnt quite a lot about Joan there, and there are some issues obviously in terms of where she's at and where her partner is at. We have some idea about where she wants to be, and that some of her concerns include things like making sure her pain is looked after. Just moving on a little to a summary or an overview of some of the things that we know can be effective for clinicians to be aware of. I've already made some comments earlier about the effect of anxiety on clinician behaviour, and at the top of this slide here you can see that what I've noted is slow down. It's very interesting to observe what happens when clinicians get anxious, and most of all what they do is they speed up and start bombarding the patient with all sorts of information, often at a time where the patient's not really processing at all. As a colleague of mine indicated some years ago, when we give bad news to a patient, we should assume that they are immediately the equivalent of a blood alcohol level of 0.05. The capacity to process, understand, retain, integrate has pretty much gone out the window. So slowing down and chunking and checking that the patient understands is a very crucial and important skill to be aware of. At the other end of the consultation and on the bottom of this slide, another perhaps quite obvious skill, but it's certainly not one we always see, is one called teach back, where essentially we're asking the patient to summarise what it is that we've discussed, where we might be going, what are the main issues of concern, and what's the plan we have for the next stage in their treatment. So amongst other things, these skills can be really, really important to establish that we have an effective understanding and a relationship where all the relevant information has at least some chance of being known to both. Kindness is not necessarily a skill, it's more of an attitude. And it's nonetheless very, very important. We know, I've had a number of patients come in over the years whose main trauma is not their illness, it's how their illness has been managed and the difficulties they've had when they've felt vulnerable and often been subjected to very bluntly delivered and unempathic discussions. So kindness is an attitude, but it informs the way we use good communication skills. And I just want to take a moment to give you a definition. It's the purposeful voluntary actions undertaken with sensitivity to the needs or desires of another person to promote their well-being. So it's not a hard and fast skill like many of the things we do in our work, but it certainly represents an attitude and a way of providing support to patients that they absolutely pick up on. A couple of other things I just wanted to note on this slide was the issue of pausing and pacing at the bottom there, and the descriptor hang time. I'm going to give you two different examples of where hang time is, one where it is and one where it isn't, and you can draw your own conclusions about which form you think has the most impact. Mary, you've asked me about the scan results, and I'm very sorry, I've got some rather bad news. So that's example number one. Example number two is, Mary, you've asked me about the scan results, and I'm very sorry, I have some rather bad news. But there's lots of things we can do, and we've got plenty of things to discuss today. And I want to make sure before you leave the clinic today that we have organised for you to speak to the nurse and the social worker. So just keep all that in mind. You can tell the obvious difference. hang time helps. Many of you will have seen Spikes. It's a communication framework. It's one of many. It's a breaking bad news framework. The important thing from my point of view about having any framework, probably a couple of points. One is find one that suits you, that you can practice and become fluent and comfortable with, so that when it comes to the crunch, you actually have a sense of what your lines and what your phrasing and what your terminology and pacing and so on is going to be like. But the other thing about having a framework like Spikes is that it forces us really to prepare ourselves for these difficult conversations. Preparation of information, preparation of the location, preparation of our schedule, what are we doing before and after, and also preparation of ourselves, because some of these discussions can be particularly taxing and they deserve to be well prepared for. So whatever it is, whatever framework that you choose, get some practice with it and if you like, make it your own. There's another framework, one of many we see in the comms area, known as NURSE. And I guess my predominant point about this is genuineness. The doctor that says to the patient, "I understand how you feel," is another example potentially of X-ray vision. So being clear about how we respond to emotion. Mary, I can see you're extremely anxious. It's understandable. I'm sorry you find yourself in this situation. And I want to just remind you and let you know that I think you're being incredibly courageous and brave, talking to you about what some of these concerns are. It's obviously a very difficult time. So genuineness is a real issue in terms of how we respond under these circumstances. Just very briefly about telehealth. We've all had a very good go at it this year, probably. Just a couple of considerations. The issue of appropriateness and safety, I think we need to keep at the top of our mind. For whom is this consultation being considered in this form? And the other issue, which is not often actively considered, is can the client patient actually hear what's going on? If they're on the phone or they're on video and they can't hear what we're saying, they won't get much out of the consultation. And auditory acuity is rarely screened for when we conduct telehealth. So it's just something to keep in mind. Think about, many of us have had this experience, think about where your eyes are. We often end up looking at the screen and our eye gaze has gone somewhere else. So getting some practice with centering your gaze, preparing a cheat sheet, and some literature suggests having a number of short consultations to maintain continuity of contact and maintenance of relationship. I'm going to just run through this very quickly. This is information that I provide to patients before they come and see me if we think telehealth is involved. You know, telehealth consultation is still a private, confidential discussion, and reminding the patient that that's what we're on about, and try and keep the kids, the dog, the cat, the telly, and leave your Pringles and potato chips in the kitchen. Can be kind of useful reminders for people that are not familiar with this format. Okay, a couple of last slides for me. This went viral last year in the media and in the medical literature. Not all things are appropriate to do via telehealth, clearly. And some recent research this year confirms that patients do not want to hear bad news over telehealth. So we'll take a pause there. I'm going to now stop sharing my screen and go across to Indra, and he will present some recent experiences using telehealth in the context of palliative care.
Thank you, John. Just share my screen. Yeah, I think John has covered a lot of the topics about communication skills that we use day to day, and that would be important in talking about difficult conversations, especially in palliative care. And this year has been interesting because things we find even challenging face to face, we have to do on telehealth. to a screen and providing some of the difficult informations and questions from the and answering the questions to the patients. So this is one example I had recently encountered with a 35-year-old man who was discharged from a metropolitan hospital with terminal diagnosis with CML after exhausting all the treatment options, and he was given from the specialist he has only few days or less than 1 week to live, and he was linked up with a community health in the regional service, but unfortunately he was not able to get admitted to that service on time, and as a consultancy service I was asked to see the patient as to bridge the gap and to provide a urgent review, because it was like, it's like usual thing, Friday afternoon consultation. So this is a 35-year-old with a partner and 3 young teenage kids, giving life expectancy of less than 1 week without any previous introduction to palliative care, and having to have that conversation. And it's a time urgent because he was so pancytopenic that he could have an event at any time. And there was, usually we try to build the rapport over time with these patients and bring up these issues slowly, but in this situation there was an urgency to cover some of the topics because we didn't know that what the weekend looked like for this patient if he deteriorated. So as John mentioned, even with face-to-face, sometimes clinicians have hard to pick up cues, and then with a telehealth, looking at a screen. And I had this conversation with both the patient and the partner, but could only see one person at a time on the screen, so wasn't sure what the other person going through, and was very difficult to sometimes pick up those cues and developing that human connection with them over a screen, and you are seeing the patient for the first time. And it's about the trust as well, building that trust with the clinician. And challenge with the silence is sometimes you are not sure whether it's a glitch of the technology or whether that you should give the time for the person to absorb those information you have given, and how to convey some of the empathy on a screen. And some of the strategies used with this challenging situation is that setting the agenda, and just rather than, because this patient has gone through a medical system over a long period of time, rather than us medicalizing things, just to give the information that you have in hand, so that patient knows that you care and you have gone through the information, and then setting the agenda. So what's your agenda? And then talking in the interview, trying to find out the patient and the family or the partner's agenda for the consultation. And I found one of the useful strategies in this situation is circular type of questioning, especially understanding what the family unit looks like and what are their strengths and resilient, and then what are the bereavement risks are. And this could be not only for information gathering, it could be therapeutic. And as John mentioned, with a screen, you have to see what the emotions, and then sometimes you can get it wrong. So its naming is quite useful to see what you are seeing is what they are feeling, and naming the emotions. And especially with some of the difficult conversations I had in that situation is invitation. And I think in that first situation, there was some reluctancy of talking about the dying process, but so we had to postpone that, but we could have general conversations relevant to the patient. And then normalizing the situation, the emotions as well, and what's happening. And this was, I was quite surprised how well they were coping with their situation, and tracing that and communicating that to the family is important, and admiration about how well they are coping with that difficult situation. So, and some of the other things I did in that consultation is give them the chance for and summarize things, and give them the chance to ask questions, and also making a follow-up appointment, so that make sure that they might give them some time to absorb the information that discussed, and then ask follow-up questions or concerns. So, and it's going forward with building the rapport and then supporting them as a palliative care service. And also the honesty, as John mentioned, about prognosis in this patient. The time I saw him, he was still walking around, and his main goal was to work in the shed and do some things. So you have to be honest, and then it's sometimes clinicians feel that they have to give a very accurate thing, but your uncertainties, if you express to the patient, they understand. And with the prognosis, when I discussed with them, so I spoke about the uncertainties, and this patient ended up living for about 5 weeks. And he had multiple transfusions through the hospital for symptom management, and we were able to connect with the community palliative care service, and he had he died at home. So it was a good outcome. I'll stop sharing the screen now.
Thank you, Indra. Thanks very much, Indra, for that. I think that sounds like an extraordinarily difficult and complex communication and treatment management challenge. And I guess what it really highlights is how much more difficult it is when we have these opportunities for engagement occur much later in the person's trajectory. So the fact that you're able to achieve so much under those circumstances is I think really very impressive, and it just tells us what is possible when we have the capacity to have these discussions and ask these questions, and do so in an empathic and hopefully trust building manner. So what I'd like to do now, we're just about to wrap up. You may have seen this slide earlier in the presentation. It's just really a reminder slide that the GRPCC has a really excellent series of resources available, and also availability in terms of providing information, answering questions and so on. So I very much encourage you to visit the site, and the GRPCC has been really very strongly supportive of a lot of the communication skills workshops we've run in Gippsland over the last 10 years. So I'd certainly commend that to you. The issue really, I guess, from my perspective as a facilitator and trainer, as a psychologist and a person interested in communication, is that professional development is the key. There is evidence that experience of itself does not confer competence with regard to communication skills training. What that statement means is that some people are very competent early on in their careers, and other people struggle with some of these issues all the way through their career because they just haven't had the opportunity for appropriate training. The training that is relevant is really behavioural learning. So the training we've offered and many others offered at places like Deakin and Cambridge in the UK and so on and so forth is small group simulated patient training. Small group is 6 people, so it's quite intimate and quite intense. There's been excellent feedback from those workshops, benefits for the community and benefits for clinicians and teams. And sometimes the focus, of course, is the communication at the interprofessional level as well, because the same processes and problems and challenges arise. Finally, for those of you who are interested in pursuing some of this learning in this area, there are a range of well-established resources on the web. There's Deakin University's new Centre for Organisational Change and Person-Centred Care, and they're really leading the challenge, I guess, in terms of dissemination of skills training and related resources. OncoTalk, VitalTalk and .com are all US-based web resources. Each is the European Association for Communication and Healthcare. There's an Australian chapter. They run conferences and training workshops and so on, so I can commend that to you as well. And of course, our very own consortium locally, which has been an excellent support to work in this area. So I'm now going to hand back to Belinda, who's going to manage the questions that we have time for before we finish.
Thank you very much, John and Indra. I will now open it up to all of our attendees, and if you would like to, welcome you to pop your videos on and ask questions. Feel free to unmute yourself. At the moment, we haven't had any questions come through from the Q&A session. So obviously, both John and Indra, you've done a fantastic job of answering those questions during the presentation. We did have a few questions come through earlier, predominantly around tools for nurse usage and information on after hours care. I will strongly suggest that you do check those resources that John has just placed up, and also have a look at the Gippsland Health Pathways. There's quite a number of information that's on those health pathways as well. So I will open it up now. Does anyone have any questions to ask? I can't actually see any videos or anyone else in attendance, but if you can pop them in the chat pane or in the question and answers right down the bottom of your screen, that would be fantastic.
Belinda, I just might jump in. We were discussing before the session the issue of dealing with cultural and linguistically diverse people in terms of end of life, and you know, questions about when should we be introducing topics of palliative care and so on and so forth. And this is not an area that I'm particularly expert in at all, but I would just make the general observation that the simplest thing to do is ask people, how would they like information delivered? How does their culture or how does their family usually, or do they in fact have any experience of dealing with these issues? And how would they like that information to be conveyed to them? We don't have to be mind readers. Patients and their families can give us lots of guidance about dealing with issues we may be unfamiliar with.
I do have Jan that has requested access. You should have access now, Jan.
I can find my mute button. Yeah, finally. I didn't know where it was. Oh dear.
That's okay. What was your question?
Well, no, more that, yeah, I just didn't know how to do it. But I'm just sort of new in the field. Probably I've been working 12 months as a counsellor with a community palliative care unit. And actually I've got, yeah, a bit out of it. Just knowing that you're doing the right thing is, but yeah, is hard when you're first starting out. But I've picked up some good things, or it's reinforced what I thought was right. So it's been great. Yeah.
Thanks, Jan.
So I've had a few participants say that they are appreciative of the session. They have received a lot of information out of it, so some positive feedback coming there. If you were unable to get your mute buttons unmuted, please send me through a message on the chat. I can give you access to that. Hopefully we can get some more questions coming through. So actually, John, one of the, and even Indra, one of the questions that did come through earlier was in regards to asking a community member or a client about their preferred site at their admission visit, and just some tools around how you might go about that. I know you answered it with the culturally and linguistically diverse clients, but just anyone in particular who may have concerns over how to approach that subject, what would be your guidelines there or suggestions?
Indra, would you like to go first?
Yeah, so one of the things I always ask about is the permission to talk about it. So that gives us idea how prepared they are, and most of the time people are actually wanting to talk about it. And then you talk about what's the advantage of talking about it now rather than later, so that how we could provide that service to facilitate them to have that goal, and also talking about the challenges, and then asking them what they think, how they are managing, and what's have they ever talk about it, and then what their preferences are. And if they haven't decided that, you can always talk about it in a follow-up appointment if you have time, and say that you would like to, you can talk about it and have a think with the family or their carers if they have any, and then make a follow-up appointment. Or some people have their strong opinion about that already, so that they said, I want to stay at home, and then that's quite clear in that situation. And I think a lot of people finding it difficult themselves to ask that question. That's the issue, rather than they are in their mind, they have think that would distress the person or the patient and the family. But that explaining, especially for people who are new to palliative care, that makes a lot of the distress, reduce the distress by talking about it. It's about our own vulnerabilities sometimes come out.
Definitely.
If I could add, because I noticed the other question, Belinda, which was on the screen there for a moment, the issue of timing in terms of palliative care or advanced care planning discussions. I guess there's a couple of issues around that, and they're perhaps in some ways unrelated. I mean, there's a very good argument for all of us to have an advanced care plan, whether we're ill or not. And we are still in short pants in terms of getting to that point in this country. So I think there's a general community education issue about advanced care planning and making that part of the normal discourse between people and families and their clinicians. But I think I'd absolutely go along with Indra's general comments that we can ask questions directly. We can ask permission to have the discussion, and of course patients are generally pretty good at giving us an indication around that. Another way I think of getting to that issue of timing is the sort of the normalised kind of approach, which is, look, many people in this situation have a lot of questions that they don't feel like they can ask. They might be things about, you know, planning for their treatment or for their limited time. Maybe things about where they'd like to die. So we kind of normalise it by raising it for them, and that potentially provides a bit of an open window, or more open window for the patient to actually start giving us some thoughts, because in some ways they may have already hinted at that if we've been attentive to the cues.
Absolutely. We do also have another question as well, just related to when families do not want a family member they are looking after to be told they are dying. It can be quite difficult to work with. And do you have any suggestions as to how somebody might go about that?
Indra? Has that been your experience?
Yeah, that's always comes very challenging still. And it's sometimes associated with cultural preferences as well. In some cultures, they don't want the person, and it's that they feel like it's protecting the person, or not having those conversations. But when sometimes you might have to have separate conversations first, so that you don't break your relationship with the patient and the family, which would be harmful. But it might not happen one conversation sometimes, but you might have to have several conversations. But sometimes the understanding where they are coming from and giving them the chance to explain, and that helps to relieve some of, and to us to understand what the concerns are, and then talk about the experience of what's the importance of the person knowing it. And they might have some different beliefs which might not be true, so that you can discuss around that, and be honest with them as well. Like if the person asks questions, as a clinician, sometimes you have to be honest, unless they are having issues with competence. But if they are a competent person, what their rights are as well. And very sensitive, this is very sensitive area. I haven't found the right areas. I still struggle sometimes with some conversations. But some families come around, and then and sometimes finding the right person in that family as well, who would be making that decision, and talking to them to build that rapport, and then slowly get into that. But most of these situations, I find that the person who they don't want the information already knew from the situation what's going on, but they are also trying to protect the relatives by not doing that. So it's that dynamic, and I think that's where one of the areas where the circular questioning is helpful, where you ask from the other's emotion, from the family member, so that they can talk each other with and give them the opportunity to talk about it.
I think I would agree with Indra completely from a kind of a challenge point of view. These are some of the most difficult things, because we have a concern about the patient being supported at the same time as we have a concern about confidentiality. And I wonder sometimes whether the question, going right back to Chochinov at the start of the seminar tonight, how do we get to know as much about that person as an individual, so that we can give them the best possible care? And our ability to do that in the best way we can might be, to some extent, facilitated by having other family members supporting the care that we're all providing. So I think they're difficult conversations, and they probably have to happen over several instances. So some of this stuff is not easy, no matter how good your skills are. They're still very difficult, challenging discussions.
Absolutely. Well, thank you very much, everyone. I am aware we have just gone over time. I don't have any more questions that have come through, so I will assume that everyone has asked their questions, and any questions they may have had have been sufficiently answered. I would like to thank you, John and Indra, again very much for taking the time to present tonight. We really do appreciate it, and thank you to all the participants who have been involved in tonight's session. You will receive a quick email link for a survey for responses for tonight. Please ensure you fill that in so that you can earn your CPD points as well if they're applicable. Otherwise, I'll say good night to everyone. Enjoy your Wednesday. We're nearly at the end of the week, so enjoy the rest of your week, and thank you all very much.
Thank you, Belinda.
Thank you.
You're welcome. Bye.